turn it. There's really With that said, in the absence of a chair and a vice chair, it is asked of the committee today to elect an acting chairman from among the members present for the purpose of this meeting today only. So the floor is now open for nominations. Mr. Porter.
Thank you, Madam Chair. For the time being, at least, I would nominate the member for Halifax-Chebucto, as he has some experience in other committees as chair, to chair a meeting today.
Okay. Mr. Wilson.
I'll second that.
Okay. So, Mr. Stroink is now going to take the chair.
I'd like to call this meeting to order. So good morning, everyone. Before we begin, can we just make sure that all cell phones are turned off or on vibrate? From there, I'd like to go with introductions from Mr. Wonderful McGuire.
Okay. I don't know what else I can say after that. Brendan McGuire, Halifax Atlantic.
Suzanne Lonis-Croft, Lunenburg.
Bill Horn, Waverly Fall River Beaverbank.
Terry Farrell, Cumberland North. I'm sitting in for Ian Rankin, the member from Timberley Prospect.
Chuck Porter, Hants West.
Dave Wilson, Sackville-Cobequid.
I'd like to, if you guys could introduce yourself as the witnesses.
I'm Frances Martin. I'm the Acting Deputy Minister of the Department of Health and Wellness.
And Dr. Frank Atherton, I'm Deputy Chief Medical Officer of Health for Nova Scotia.
Peter Grohl, I'm the Acting Director of Finance for District Health Authorities and Long-Term Care.
Excellent. So I will turn it over to you guys to start the proceedings.
Thank you very much, Mr. Chair. I have a few opening comments to help put into context the chapter of the Auditor General's report. Thank you very much for asking the Department of Health and Wellness to appear before public accounts today. It is an opportunity to really focus on some of the excellent work that is undertaken day in and day out with our public health group. Certainly pleased to explain specifically the public health surveillance activities and how we are working to enhance them. Public health has made great strides through the ages. If you just simply look at where we are in terms of vaccination, hundreds of thousands of people at one point in our history died of smallpox, and today the disease has been eradicated through immunization. Of course, not every improvement we make is that dramatic, but we do continue to make important advances. We also make significant investments in public health in Nova Scotia. The Department of Health and Wellness has a budget for public health today of $25.4 million. We have just under 70 FTE staff positions with the department this fiscal year, and there are hundreds of staff who work in the district health authorities across the province, and many of those are involved in frontline delivery of services. In addition, the district health authorities have a collective public health budget of $29.3 million. And we have 9 medical officers of health around the province to provide expertise and leadership. As you know, surveillance is a critical component of our work in public health. For both the prevention of disease and the protection and promotion of good health, we need reliable information about the health of our population to do this work. Public health surveillance requires appropriate process, skilled expertise from epidemiologists as well as information systems. Over the past couple of years, we have enhanced our epidemiological capacity. We've gone from 1 provincial epidemiologist to 4 at the Department of Health and Wellness. There are also 4 epidemiologists in the district health authorities and 1 at the provincial health lab. Like other provinces and territories in Canada, our surveillance systems have done a fairly good job, but there is need for improvement. These systems allow us to meet our legislative responsibilities to report on notifiable diseases, identify, manage, and notify the public of outbreaks. But this work could be done more efficiently and comprehensively with improved information systems. Building these information systems to better manage public health surveillance is a challenge for all provinces, but is one that we in Nova Scotia are taking very seriously. We continue to work with our colleagues across the country, and we recognize that Nova Scotia needs an electronic information system with many integrated components, including an immunization registry and other components for case managing, tackling both notifiable and non-notifiable diseases and other public health indicators. Getting these new surveillance systems in place will improve our ability to manage immunization, address outbreaks, reduce the odds of data entry errors, and enhance the breadth of surveillance activities beyond notifiable diseases. I'd like to give you a bit of background on the path Nova Scotia has taken to make the necessary improvements in our public health surveillance systems. In 2004, the Government of Canada, through Canada Health Infoway, provided funding to support the development of a pan-Canadian public health surveillance system. This system, which we call Panorama, the concept is one system with a large number of integrated components. Users of the system can choose which component they need and tailor them to meet their needs. In Nova Scotia, we recognize the benefits of having a national system. It is helpful to be able to share information among provinces and with our federal partners. So we did our best to participate in the effort to develop Panorama. However, the initiative became too costly, the development was too slow, and we weren't certain that at the end of the road it would meet our needs. We decided, therefore, to put on hold our participation in the development of Panorama in 2009. The provinces that continued working on Panorama are only now just getting some components of the system up and running. For example, the immunization management module is implemented in 3 out of 5 participating provinces and territories, while the surveillance, case management, investigation management, contact management, and outbreak management modules are still in the planning stages in other jurisdictions. There is no one province or territory that has a comprehensive system in place. So Nova Scotia hasn't necessarily missed out on anything by pausing our participation in Panorama over the past 5 years. Now that Panorama has been further developed, we can look at that system and other options that have emerged for Nova Scotia to once again consider the best options to protect the public health of Nova Scotians. We have completed our research into all other options available. And to be clear, there is no single off-the-shelf system that will perform all public health surveillance functions for us right away. We either need a set of various systems that will talk to each other, or one overarching system like Panorama was intended to be, with multiple integrated components. Any option we choose will require tailoring, and that will take time. Through our research, we have identified a short list of options that we believe could work for Nova Scotia. We are now determining the process of choosing the best one for our circumstances and getting it in place. We expect this to take several years before it is fully operational. While we continue our work on that front, there are a number of other initiatives that will help us improve our public health surveillance, as the information system is just one component. We are close to completing a provincial health profile. This profile will report on a set of indicators that give us a clear picture of our population's health. It will describe our population, how healthy we are, and the factors that affect our health. Indicators in the profile will include physical activity, smoking, fruit and vegetable consumption, and life expectancy. The profile will help us do a better job of planning, allocating resources, and determining what we can do to ensure that Nova Scotians are the healthiest they can be. We have established a process for regularly reviewing and updating a list of notifiable diseases. In fact, we initiated the review process just this February. By the coming October, we will have established a formalized process for seeking feedback from stakeholders on notifiable diseases and a reporting system to ensure that their needs are being met. In addition to that, we are working and making progress on the public health protocols. We reached a milestone in 2010 when we established our public health standards. They reflect our vision for public health, set expectations for the work in the district health authorities and the department, and support a shift in our system to place more emphasis further upstream. We are reaching other milestones this year with the implementation of the public health protocols. They describe the mandatory core work of public health along with roles and responsibilities in order to achieve the vision set out in the standards. This work is in the area of healthy development, healthy communities, environmental health, communicable disease prevention, management, and response. We will start rolling out these protocols very soon. Turning to the Auditor General's report, it rightly noted a number of areas for improvement in public health surveillance. We agree with all of the recommendations, and I think you can see that we've made significant progress in carrying out these recommendations. I want to stress that the Department takes the Auditor General's recommendations very seriously. In many instances, we've started work on recommendations even before the report has been released. For example, during the H1N1 outbreak, the Auditor General conducted an audit of our pandemic preparedness. So this audit was happening at the same time that we were learning through the pandemic experience. Not surprisingly, our lessons learned and the Auditor General's recommendations mirrored each other. We completed all of those recommendations by 2013. That was within a 4-year period that the Auditor General expects it should take to complete these sometimes very complex recommendations. Some of the results of that particular audit were an increase in the number of epidemiologists in the department's head office and in the district health authorities. Also, the All Hazards Plan was created for the health system by the former Department of Health Promotion and Protection and the Department of Health. As the largest department in government, we naturally have the most audits and recommendations from the Auditor General. From 2005 to present, the Department of Health and Wellness has received 349 recommendations, and we have completed 75% of them. So in conclusion, I give you these figures and background to emphasize our work at the Department of Health and Wellness. The health of Nova Scotians is government's highest priority. We welcome regular audits to help us improve our work and to meet that priority that we are committed to in terms of continuous improvement. I do thank you for the opportunity to talk about the good work that we are doing, and I welcome your questions. Mr. Chair.
Thank you very much. I will turn it over to Mr. Porter. It is now 9:15, and we'll stop in 20 minutes.
Thank you, Mr. Chair, and Ms. Martin, you're probably getting tired of this chamber. We've seen you an awful lot in the last little while, especially through the estimates, and that's going to continue. So good to have you back again this morning and your colleagues with you to answer a few questions on what we would all agree is a pretty important topic. I want to kind of go to this whole electronic system first. I can give my social insurance number anywhere in the country if I want to, and they can tell me all about me. They can do credit checks. They can do all kinds of things. How come it's so complicated? There's the part I could never figure out. This seems pretty simple. We're a small province. We're 900,000 and some change in residents, and you know, it shouldn't really be that hard. We're not big geographically as a rule. IT is not new. It's been around for quite a few years. I realize that leading edge changes every day, or maybe I should say the bleeding edge changes every day, but you know, leading edge technologies come along. There are writers of programs who are well known and who do wonderful work and can write just about anything you'd ever ask for. You talked a lot about in your opening comments there about the I guess it doesn't work well together. It's so big, it's broad, things don't work, you know, they don't talk, or you'd have to write something specific to get one to talk to the other. Instead of doing that, I can't imagine why we just wouldn't hire a writer to go out and probably, and I don't know because I don't know the numbers, maybe you can speak to that as well, by way of dollars to do that, but and costs associated with it, but I would think it would be a lot cheaper to go and write a program that would work one for all, and as opposed to trying to mirror all these, make them all talk. But I'm no IT specialist. I'll tell you that right up. But I do look forward to your comments on where we're at with this thing and why it's so difficult for something that at least appears on the surface to be quite simple. Thank you.
Sorry. Oh, sorry. Ms. Martin, sorry.
Thank you very much, Mr. Chair. And thank you as well for welcoming us back to this room. I think it's important early in this round of questioning to recognize that sometimes the toughest decisions that we can make is to make the decision that the system we're pursuing in this case is one that at the end of the day, even though we have money invested, that it is probably the toughest decision you can make is a determination that we could put more money into it and more effort into it, but really we're not on the right course to get the system that's necessary to give us the sort of information and the functionality we need. You are correct that Nova Scotia is a small jurisdiction relative to other provinces in Canada, but when it comes to public health surveillance, of course, some of these diseases and other factors that we're tracking, they know no borders, and
Absolutely.
So it's really in Nova Scotia's interest to participate with the other jurisdictions in Canada, and that's what we were really dedicated to in our participation in the development of Panorama in 2009. We do have a very high success rate, and I do know that we get examination and audits from Canada Health Infoway, which is our federal funder, and of course we do get examination from internal audit and the Auditor General's reports in terms of our processes around developing some of these complex IT systems. So our success rate is very high in developing these systems, but that does mean that, you know, in the case of Panorama, we really took a tough decision, as other jurisdictions in Canada did as well at the time, to say that we could pour more money into it, but it would not be a good public expenditure. Dr. Frank Atherton, I think, would have some additional points in terms of the system and really what we were trying to achieve, and I'm just going to ask him to elaborate.
So thank you, Mr. Chair. And it would indeed be wonderful if there was a system we could just go and buy off the shelf or bring somebody in and simply build it. Part of the complexity of modern public health systems is that information comes from a wide variety of sources, and so if we think about just the communicable disease world, for example, we have information coming in from the laboratories, information from physicians, from public health nurses, from a range of different sources, and part of the art is part of the challenge is to marry all those sources up, and so we're looking for a system that can do that. In fact, when we took the decision to suspend our involvement in the Panorama programme, we did look around at what could be used as an interim solution, and one solution that we did subscribe to, and we currently use for communicable disease, is a process called ANDS. It's the Application for Notifiable Disease Surveillance. And it kind of does what the member is suggesting, but there are limitations to what it does. So it does serve us reasonably well, but it's not perfect. And the problems with the system that we currently have are that, first of all, many of the inputs are paper-based, and when you have paper-based information being input into a database, there's always room for error, error and duplication. And so the current system we have really, which is sort of an off-the-peg version of a system which was developed and it is used in other Canadian provinces. The problem with it is that it's inefficient and ineffective, and it doesn't quite do what we need. So we do have interim solutions. We have bought into those. We are limping along with those. But what we're looking to do, in line with the Auditor General's recommendations, is to build a more effective, more modern system.
Thank you. Mr. Porter.
Thank you, Mr. Chair, and thank you both for the responses. Again, I'm not a widely technical person. I mean, I'm an average probably. I can use a computer. I can build databases with access and simplicity of things. Enter data, you know, we do it in my office. It's rather simple. I guess I get a little confused around it all because it does seem so simple. And maybe it's, you use the word complexity. I'm sure that all of these different ideas make it that way, but quite simply, all you're really doing, and I look forward to the response here, because I'm going to make it very simple, very high level. People would think you're collecting data and you're entering it into a system and you're collating it, you're analyzing it, you're developing numbers of what exists out there, what doesn't, you know, what treatments have been done, and, you know, all the things that you would do typically once you've done the surveillance. Am I right there? Is it that simple? It certainly appears that simple, and if you want, you can actually speak a little bit to how that is captured. I would just look for some clarity. I mean, if your public health nurse goes into a home and there's an issue with some disease, if you will, you know, whatever it might be, is it as simple as that, as that person capturing that data and entering it somewhere, and then we're doing the rest with it? Thank you.
Correct.
Thank you, Ms. Martin.
Thank you very much. I guess, you know, what's important to lay out is...
Right up in front of you.
Sorry? Okay, thank you. What's important to lay out is the road ahead. We are working now with our Atlantic partners, with our federal partners, and certainly focused inside the department to pull together the needs for the system. And when it comes to developing an IT system, a system will do what you tell it to do. So therefore, it's very important to do considerable planning in terms of what instructions you want to create, in terms of what drives the development of that system. We are doing that work right now. We're doing it with a focus for what is best for Nova Scotians, and we're also doing it with an eye to the collaboration within Atlantic Canada, our federal partners, and as well, we have studied in detail the systems in the other jurisdictions. And this is where it is an advantage to be where we are, in that when the system that we ultimately have in Nova Scotia, we have the benefit of the lessons learned from elsewhere in Canada. So in terms of timelines, what becomes important for the go forward is that we will be doing that needs analysis, we call it, throughout the next coming months, and we would look to therefore have a proposal ready for the 15-16 budget year in order to make the next important step in developing the system.
Mr. Porter?
Thank you very much. And we, I'm going to assume, is the Department of Health.
That's
and
correct.
Thank you. You noted in your opening statement as well, under your approach, and you were talking about going forward, you talked about the panorama, and your comment here was, however, the initiative became too costly. The development was too slow, and we weren't certain it would meet the needs. How costly? What are we talking about here in numbers? I mean, what are we really looking at?
Chair, it was. It's very difficult at this stage to know, in terms of the go forwards, exactly what the costs will be. We haven't done the. We haven't gone out to tender yet, and so we don't have clear cost estimates. But if we look back to 2004, when we first launched on Panorama, there were some costings done at that stage, and it was in the order of $10 to $11 million. So it was an expensive program that we were embarked on with Panorama. And as the Deputy Minister says, that's why, in a way, it was quite difficult to make a decision to halt implementation at that point, because we had gone down a certain way down the road. But clearly the costs were very significant, and we wanted to be certain that we got it right. So we don't have accurate costings for the future system. We're currently working on those, and as the Deputy Minister says, we are developing a plan for the future, which will include better cost estimates. But perhaps that gives a ballpark figure.
Thank you. Mr. Porter?
Thank you. And just maybe, Deputy, just for clarity, you talked about 15-16 budget year and going there. Does that mean that you're hoping to have a cost? I understand your point, Mr. Atherton, as well, that how could you know what, if you don't know what you're going to buy or build or develop as a system, what it would cost? That would be very difficult at this point, I would think, to determine. But by that period in time is what you are referring to, having some sort of line item to put in the budget by way of making this happen? Is that just looking for a little clarity around that, maybe from Ms. Martin?
That's correct. That again, just in the tendering process, of course, you don't know sometimes exactly what something will cost until you've actually gone through the procurement process. So what we will have for 15-16 are the needs worked out in terms of what we want the system to do. And then we will go through the regular tendering process then to be able to assess what the exact costs will be.
Thank you. Mr. Porter?
Thank you, Mr. Chair. And do you have a goal or a figure in mind there that you're trying to stay within? Sometimes that often has a great bearing on what you do develop or what you do buy. I mean, or you know, if you're trying to stay within a figure, is there something there in mind?
Ms. Martin?
At this stage, we are really focusing on assessing the systems that are in use elsewhere in Canada. That's a process where we will be working with our partners in the system, the many people, in addition to the Department of Health and Wellness staff, working with staff in the district and information management specialists to determine the needs for the system that will drive the design. So we do not, at this stage, have a number in mind. That would be purely speculative.
Thank you. And you state also in your comments there that there is no province that has a comprehensive system in place. I guess that would mean, although you might work with some other provinces, there's nothing out there right now that is satisfactory, for lack of a better word, that Nova Scotia would be interested in mirroring in any way? Or part of, or?
Ms. Martin?
I'll let Frank answer that detail, but it's fair to say that no, there is no one jurisdiction that has that comprehensive system now in place that was envisioned in 2009 when efforts were put into Panorama, but Dr. Atherton can give you additional detail on that.
Thank you.
So as Deputy Minister says, there's no single solution which is the standard across provinces. A number of provinces have continued with implementation of Panorama and are now reaching the point where they're able to use that for some of their public health information needs, particularly around communicable disease surveillance and immunisation management. There are a range of other issues within the public health world, child health, information systems, vaccine management registries, which wouldn't neatly fit within any on-the-shelf solution. And so the direction that we will be taking, we expect to be taking in Nova Scotia, is to look at all of our business needs across the whole range of public health. And yes, to say, well, in the communicable disease world, we need to find a solution which is consistent with what other Canadian provinces are using. But maybe for child health or for the management of vaccine supplies, we need something different. And we've currently, in the last year, been doing quite a significant piece of work to develop a strategic direction for our public health information system, which is leading us to conclude that we need a suite of solutions, some of which will perhaps be similar to other provinces, to Panorama or other models that are being used, and some of which may be standalone within the province.
Thank you. Mr. Porter?
Thank you. And Panorama, as you've outlined it here, was it just too much, too complex, too big, too broad, trying to capture too much? Is it why it didn't work or not focused?
Mr. Athen?
When we suspended Panorama in 2009, the rationale for that was really that, first of all, it was a very complex system, but not sufficiently developed to be assured that it would be successful.
From an IT perspective there, you mean?
From an IT perspective and in terms of meeting business needs. It was felt that it was more suited at that time to the needs of larger provinces, and that to buy into a very complex information IT system for a smaller province may not be cost effective. It was also recognised at that time that the provinces that were actually ahead of us in terms of implementation were running into some delays, and so it was felt that we should bide our time. We should wait and see how Panorama played out rather than go into it at that time.
Thank you, Mr. Porter.
Thank you for that. So, with nothing really in place yet, that you're working towards something. How are we capturing data now that we feel comfortable enough, that you're working with today? We've gone through some pretty significant things, as you know, in past years in this province by way of H1N1, and there'll be others, there's no question, and there have been others in the past. So, how can Nova Scotians feel comfortable today that, we are capturing this stuff and doing what we need to do with it by way of diseases, communicable diseases?
Ms. Martin?
To preface some of the detail that Dr. Atherton will supply, we've gone through some pretty significant flu seasons.
Mm-hmm.
We've gone through certainly the experience of H1N1, and as I indicated in my opening comments, following H1N1, there was a very exhaustive examination of what did we do based upon the resources available at that time. What could we do better? And certainly we had a Auditor General report for which we've addressed all of the recommendations coming out of H1N1. So an information management system is certainly an assist. A comprehensive information management system is the goal. But we certainly have a number of measures in place to report information, and Dr. Atherton will detail that, but I do believe that Nova Scotians have every reason to be confident that between the district health authorities and the Department of Health and Wellness, as well as our federal partners, that we have capably managed serious public health events and will continue to do so.
Mr. Athen?
Thank you. To continue that, I wouldn't like this committee to labour under the misapprehension that we don't have any system for public health surveillance. We clearly do. The issue here is that our systems are rather old. They're not fully fit for function for the current environment we're in. So just to continue with thinking about the communicable disease world, we do, as I mentioned earlier, have a system called the Application for Notifiable Disease Surveillance, and so that does capture information from clinicians, frontline GPs, nurses, and when they see an infectious disease in their clinics, they are expected to notify the Public Health Department about that. We do have a list of notifiable diseases, and they're widely available. All physicians and nurses have access to those, so they know what they should be reporting. We do have a system for the laboratory to provide us with information.
Order. The time has come to an end for the Conservatives. Now I turn it over to Mr. Wilson.
Thank you, Mr. Chair, and welcome back. Nice to see you here again. I know the Deputy Minister has been before us for a number of days in estimates, and it's nice to see Dr. Atherton here with us and Mr. Kroll. I know how important it is for public health to be tracking and understanding diseases and the work that's being done there, and I understand what Dr. Atherton was just finished up with, is that there is a reporting system in place, and Nova Scotians should feel confident that those indicators and alarm bells go off, I think, when health officials feel that there is something going on in any region of the province. And I know that public health and government learned a lot over going through H1N1 and some of the flu seasons that we have had, and I look forward to the continued work that public health does, and responding to the recommendations through the Auditor General reports, because I know of all the departments, health has been the one that has acted more efficiently than any of the other departments, and I'm confident, even with the new government, that will continue, and I commend you for that. So one of the things that is also important to public health is to know the determinants of health. And I look under recommendation 4.3 in the Auditor General's report, and I'll quote a bit of the response from the Department of Health and Wellness. It said, given public health's shifting emphasis from individual to population and a greater focus on addressing the determinants of health, public health acknowledges the need to enhance surveillance and non-notifiable disease and determinants of health. So how important, would you agree that knowing the determinants of health is extremely important on moving forward and trying to address some of the health concerns in our province?
Absolutely, and there are many players certainly in that equation. One of the areas that I'm sure you're well aware, and I really appreciate every opportunity to speak to the importance of the physical activity and healthy eating and those important aspects of lifestyle, which is what prompted us to develop the Thrive strategy. And that is reaching out to school children all across the province, working with various publicly funded institutions on ensuring that we keep healthy nutrition in mind. And we recognize that that it's important to create the conditions where people, to the best of their ability, can make the lifestyle choices that will support their good health. And we do recognize, of course, that in that regard, not everyone is on an equal playing field. That's why we are quite pleased in this fiscal year to have $300,000 dedicated to chronic disease. And when you look at the underlying contributors, not in all cases, but in some instances, we know that physical activity, healthy eating, use of tobacco, consumption of alcohol, and so on, are all factors that kept in proper proportion can contribute to our health. So we look forward to working with our community health boards as just one partner. We do have many partners, but that is one that we look forward to the various activities they'll be involved in getting Nova Scotians engaged to the extent they can through that additional contribution and funding in this coming fiscal year.
Thank you. Mr. Wilson.
Thank you, Deputy. I know from my experience, not only as former minister, but as a paramedic, and just educating myself on the social determinants of health, and it's not always about the exercise and the food intake that you have. There is, and I could list a number of publications, studies, really attitudes, I think, of the majority of those who work within public health that believe there are many causes to the health of a population, and that's extremely important to understand and move forward on, and extremely important for the government to ensure that they provide programs, not only like Thrive, but throughout all the departments to make sure they have the greatest impact to improve the health of our population. So that's why a number of months ago I was very concerned when I read a column from the current Minister of Health. It was February 6th and through the Kings County Advertiser. And I'll quote a little bit here, and I will table it for the committee, but maybe after the committee because I'll be looking at it for a few minutes. And in the column the minister wrote, a number of things stood out to me, and not just to me, to many groups, because I know the minister has been hearing from them over the last number of months. I've attended different meetings and groups that have expressed concerns of the minister's column. And one of the quotes here is, do we need to take further drastic measures? Some have suggested looking at the bank model. Imagine if healthcare worked like banks. Patients would have to prove they practice a healthy lifestyle before receiving assistance. They would have to prove that they practice the basic tenets of proper eating and exercise. Such would to save money for those who have not abused their health and need medical care. And it goes on, and maybe I'll get to that in a few minutes. I'm just wondering, and I know the philosophy of public health. I've worked with the department for a number of years. So maybe I'll ask Dr. Atherton if the Minister of Health seeked any advice or support in writing this column. I know as minister, when I put anything out in public, I usually asked the experts who work in the field what they thought about what I was going to provide or put into a column or media or talking points. So I'm wondering, did the minister ask for any advice from public health on the column that appeared in the February 6th, 2014 issue?
Thank you. Mr. Atherton.
So thank you for the question, and for underlining the point about the determinants of health, which are really important to us in government in terms of improving the health of the population. And the member is absolutely right that it's not just what we do in the health sector which drives population health. In fact, maybe 10% of the health sector activity is what makes and keeps us healthy as individuals and as communities. And the other things which are really important are around our access to education, our access to employment, good quality employment, our access to a healthy environment. So I'm grateful for the comment. The minister did make some points which have resonated with people about the personal responsibility for health, and I don't think anybody would argue that individuals do have some responsibility to keep themselves as healthy as possible. As the Deputy Minister has mentioned, we do have a belief that we need to create the environment that supports people in making those healthy choices. And the Minister has been fully involved in discussions about that. He understands the concept and is deeply committed, I believe, to supporting healthy environments to make and keep people healthy. And that's why, as I understand it, the government has renewed its commitment to the Thrive strategy, and we are continuing our approach not just to tackling individual lifestyle issues, but also to making Nova Scotia the place where people can choose and can be healthy.
Thank you. Mr. Wilson.
Thank you, Dr. Atherton. And I know you've only been working with the department for maybe a couple of years now, I believe, but you didn't answer the question. I asked, did the minister ask for assistance from public health on writing the column?
Mr. Atherton.
He said he didn't ask me for specific advice. My understanding is that was a personal opinion that he was writing for the journal. We have subsequently had discussions with the minister, and he understands the concepts of both personal responsibility and the broader determinants of health, just as we've been discussing.
Thank you. Mr. Wilson.
Thank you, Dr. Atherton. Because I mean, after the comments or after the column appeared, you know, our caucus, myself, we were very concerned with that column and what was said in it, and not for 1 minute did I believe the public health, yourself or Dr. Strang or anybody in the department would want to approve of the column. So through Freedom of Information, we did make a request into the department to try to find out if there was any support for his column, and I'll table this after I'm finished with it. It was an email from Steve Machette, who's the manager, Prevention and Problem Gambling Services, Mental Health, Children's Services, Addiction Branch of the Department of Health, and it was from Mr. Machette to Dr. Strang. Good morning. Not sure if you're receiving the same questions of bewilderment as I am around the minister's op-ed. And the response from Dr. Strang was, no question coming my way, but this gives me angst. However, I can't and won't try to explain the minister's comments. I think the only thing we can say is that the minister writes this column on his own in his role as local MLA, and it certainly does not reflect any of our thinking. And I couldn't agree more excuse me, I couldn't agree more with those comments from Dr. Strang, and it does give me some concerns that the minister would go out on his own. He is the Minister of Health. I understand he's the MLA for his riding, but after the column, it wasn't just myself. I know that the many groups that support those low-income Nova Scotians, those Nova Scotians find themselves in a position that I don't think any Nova Scotians would want to be in. Started to raise a flag and say, wait a minute here, does the minister understand the social determinants of health? Does he know that it's not just how much exercise you get that has an impact on your health? Does he know that age, sex, and constitutional factors have a role in it? Does he know that individual lifestyle factors has a role in your health? Does he know that living and working conditions like education, work environment, unemployment, water and sanitation, healthcare services, housing, agricultural and food production have a role in someone's health? And of course, the general social, economic, cultural, and environmental conditions. These are things that Canadians have been working on for a number of years, and I'm still concerned because I know that the provincial coordinator for the Transition House Association of Nova Scotia wrote the minister, copied myself on the letter, and many other people who were concerned with those comments. And I'll just quote from this letter, and I will table all these pieces that I've quoted from after the committee finishes. And it's quote, this is from Pamela Harrison, a letter to the minister, and I quote, says, to suggest that people on income assistance or low income, or in fact anyone who struggles with their weight and exercise regimes, do so consciously and with disregard to their own or other health is problematic. And she goes on to say, at the end of, quote, at the end of your if healthcare worked like banks comments, you said, and I quote, but copying this approach would be archaic and inhumane, and is not for me to judge those who are dependent on the system. Your article, in fact, does did just that. You suggested that people misuse our income assistance program, are careless of their health and fitness, and are headed for disaster and taking the rest of the province with them because of the costs they incurred. Ms. Harrison also goes on to say, we respectfully suggest that an apology is owed to those on low income or income assistance who are doing their very best for themselves and their families within the constraints of limited funds, housing, transportation, mental and physical health support. We are available for discussion of this important issue. So, as I said, it wasn't just myself and our caucus that took offense to the column.
Mr. Wilson, can we just focus on the topic at hand? This is a long question, so if we can just get to the question, we'd be greatly appreciated.
Oh, definitely, and this is
It's
definitely
a long
on hand.
story, and
As
so
I
if we can get to
read,
the
as I
question, it'd be
read the
great.
recommendations from the Auditor General, in the recommendations and the comments from the Department of Health, it states, given public health shifting emphasis from individual to population and greater focus on addressing the determinants of health, public health acknowledges the needs to enhance surveillance in non-notifiable diseases and determinants of health. As a member of the committee, we have before us the Deputy Chief Medical Health Officer, who I've worked with for a number of years. We have the Deputy Minister of Health, who I've worked with for a number of years. And I know that this is not, the column that we talked about with the Minister is not reflective of the work that this department does and reflective of what public health does. So I would like to ask the Deputy Minister, with the comments that and the concerns that have been coming into the office, I know they have, has the Minister either apologized or responded to Pamela Harrison's letter that she sent, and has he met with Pamela Harrison to discuss the determinants of health?
Ms. Martin.
Thank you very much. I'd just like to, I guess, respond first by indicating that certainly since the Minister has been in the department, he has expressed a tremendous amount of emphasis on the importance of Thrive and strategies like that. When you look at some of that correspondence you referred to, really taking it from a holistic view as opposed to certain excerpts, you'll see that his statements are really a commitment to the extent people can, and everybody has a different starting place. I think he recognizes that it's important for those who can do what they can to ensure that they prevent the onset of chronic disease and various other things that influence people's health. So through activities like Thrive, through the commitment of the funding for the $300,000 to address chronic diseases in this year's budget, those are at least two important areas that this minister I know is very committed to help those who need, in some case, community support to be able to fully participate, whether it's exercise or proper nutrition and so on. So what's interesting, of course, is those articles have served to create some dialogue, which I think, you know, by and large is important. And during the tour, the minister had, on many occasions, taken the opportunity for the hundreds of people that we met across this province to express, you know, his interest in encouraging those to take the steps that are necessary to look after their health, and very interested in and engaged in the discussion on the volunteers across the province to assist those who need some support from the community and others to take advantage of lifestyle choices if they themselves weren't able to do that on their own.
Thank you. Mr. Wilson.
I think every Nova Scotian should be concerned when we have people within, which I believe experts within public health and those that have built their career around supporting health services, use things like bewilderment and angst. It gives me angst. and that's from our chief medical health officer. We should be concerned, and so I would like to ask. I know I only have about 8 seconds, I think.
You got a minute.
A minute. I'd like to ask the Deputy Chief Medical Health Officer if he would agree, or does he agree with the comments from the Chief Medical Officer, Dr. Strang, about the fact that you can't explain. I know the Deputy Minister tried. You can't explain what the Minister said, and it was him on an individual basis when he wrote the column.
Mr. Atherton.
So, thank you. And yes, clearly the Minister speaks for himself, but as I said earlier, really, in public health terms, we are committed to developing a system which supports people to be healthy, to lead to the healthiest lives they possibly can. And that remains government policy, that remains the policy and the practice of the Department of Health and Wellness, and the Minister is, I believe, committed to that. So that's why I'm delighted that we're continuing with Thrive as the programme, so that we can build a healthy Nova Scotia.
Thank you, Mr. Atherton. I'll turn it over to the Liberal. Start over at the other end with Mr. Maguire.
Thank you. This is different. First of all, I just wanted to say to the member opposite, I respect his experience and his opinion, but this government encourages free thinking and proper constituency representation. My question to you is, so the implementation of Panorama started in 2004 and was paused in 2009. So for me and the people of Nova Scotia and the people in my riding, I'd like to know how much money and resources were spent over this time frame.
What's the number?
Oh, sorry, Mr. Martin. Sorry.
Yeah. So thank you for the question. The estimate at the time was approximately $11 million for the development of the system. I am very pleased, though, to tell you that some of that money went for the purchase of certain computer equipment, for example, servers that would have been necessary to have supported a system like Panorama. And recognize at the time when we paused, we were able to reap the full advantage of that investment of public dollars into the equipment, and were able to direct the use of that equipment for other priorities that were taking place at the time. For some of the other funding that would have been expended during that 05 to 09 period, there was work completed in terms of some of that analysis that is necessary to do the system design. So as we turn our focus back to and intensify our efforts on the design work, we are fully utilizing the analysis that was created in that 05 to 09 period. So in summary, I'd say that we were doing our very best to reap the benefit of the investment made, even though we did have to make a very difficult decision, like other jurisdictions in Canada did at the time, to pause our efforts.
And just a quick follow-up, and then I'll pass it. My background is IT, so education-wise, I'm a programmer by trade. I've implemented many servers and networks, and so I have a bit of an understanding on what goes into setting up the IT systems in large corporations and organizations. So for me, this comes down to services provided, but it also comes down to dollars and cents. The people in Nova Scotia always are concerned about where the money is being spent and if it's being spent wisely. So the follow-up question for me is, for the people of Nova Scotia and the people in my riding, was this money well spent?
Ms. Martin.
I would say that anytime that you put a system on pause, there's a certain amount, a loss of efficiency in terms of the dollars invested. But we did our best, given the difficult decision that we had to make, to repurpose those dollars, which I did reference in my last answer. And so I think what's important in the here and now is to focus on what we're doing today in terms of redoubling our efforts and working with our federal partners, working with our Atlantic Canadian partners and across Canada to get serious attention placed back on the development of this important system. And we are looking toward and working hard to be ready for the 14-15 fiscal year.
Thank you.
Thank you, Ms. Martin. Ms. Suzanne Lode-Croft.
What improvements have been made in the past few years in public health surveillance? And for example, you have the H1N1. What did you learn and implement following that experience?
Ms. Martin.
Great. That's an important area of Dr. Atherton's work, so I will ask him to address that question.
Dr. Harrington.
So thank you. 2009 H1N1 was indeed a challenge in Nova Scotia and elsewhere, and we did learn a huge amount from that and have improved our system since then in a number of ways. First of all, as I think I mentioned earlier, we did develop an interim solution, a notifiable disease surveillance system, and the AND system, so that we are better able to track diseases, to know when outbreaks are occurring, and to understand the burden of notifiable and communicable disease in the province. We also did build our epidemiological capacity. I think Deputy Minister mentioned in her opening comments, we have expanded our capacity both in the Department of Health and Wellness and in the district health authorities, so we now have 9 epidemiologists across the province altogether. We also renewed our efforts to make sure that our notifiable disease list was up to date, and we've created a group which allows us to do that. We've also worked very closely with colleagues in other provinces and other jurisdictions to improve the way that we share information across boundaries, because diseases don't know jurisdictional boundaries, and we do need to know what's happening elsewhere in other parts of Canada and indeed across the world. And we do have a stronger system now for complying with our requirements under international health regulations. So back in 2009, we had very little information about what was coming out of other parts of the world, specifically coming out of China and Mexico. And we now have far better information. We have a system of IHR point people. I'm one such in Nova Scotia, and so we get much better information. And so, for example, we now have a lot more understanding of what's happening in China at the moment around H7N9 and in Saudi Arabia around coronavirus, these viruses which could cause us problems. So our ability to look outwards is much stronger. We've also strengthened our processes for some of the nuts and bolts interventions that we need to control diseases. So we do a lot of education with physicians. We make sure that they understand notifiable diseases. We communicate regularly with them through Doctors Nova Scotia and directly. And we've also brought new health workers into the system. So, for example, in just the last flu season, we brought pharmacists on board so that they can support immunisation with flu vaccines. So there's a whole range of things where I would say things are better than back in 2009. That's not to say that there isn't still work to be done and that we couldn't make further improvement, and that's really what we're trying to do with the public health information system as we go forwards.
Thank you. Mr. Horn.
Yes, thank you. Thank you for being here before us today. I think it's a good thing that you're here to give us some support on where we're going with communicable diseases. The Panorama program obviously wasn't working very well to your satisfaction, and I note the Auditor General talks about identifying information system that you would like to use. Obviously, you've kind of are gathering information from other systems and putting it together. Can you just comment and take us through maybe some of the more important parts of putting a system together that you'd be satisfied would meet the national and international criteria?
Ms. Martin?
Great. Sure, and perhaps it's important to note that Panorama is the system for a particular company, and so as we go forward and do that design work and determine what sort of a system we need, what sort of information does it have to yield for our public health officials so that we can ensure that we have good information to manage any public health outbreak, or even better understand, and that's one of the important areas, of course, is the immunization rates among Nova Scotians. And as we go forward and do some of that detailed work, which Dr. Atherton can supply some additional detail, what we would be doing is going forward with a procurement and going out to the marketplace to determine what companies may have solutions to address our needs. And so recognizing in this field some of the improvements that Dr. Atherton was referring to is that, you know, when it comes to supporting individual Nova Scotians, in this last fall's flu season, we, for the first time, were able to have pharmacists in drugstores that are in communities throughout Nova Scotia provide immunization very conveniently, in addition to doctors' offices and clinics that might be arranged by the District Health Authority. So I just raised that as one area that this is a system that will have to collect a broad array of information from general practitioners, from pharmacists, and from health providers all across the province, and be able to very quickly provide us information to make decisions in terms of you know, whether it's managing an outbreak, or it could range to determining that we need to redouble our efforts in educating the public on the importance of coming forward for general immunizations or the annual flu shot. So as an overview, and perhaps I could ask Dr. Atherton to detail.
Well, maybe a specific example might help. And we talked about the lack of a vaccine registry as being a significant gap in our systems here. Immunisation is a complex subject, and what, of course, happens with vaccination is children get vaccinated either through the general practitioners or through public health nurses, and a paper record gets generated that then gets compiled. Now, that's fine, it's well and good, and but what it doesn't tell us the level of population coverage for immunised children. And so when we have a threat, as for example we have now with measles around in other parts of Canada, not fortunately in Nova Scotia, it's very difficult for us to look at our records and to say, well, which children do we need to target for immunisation with measles vaccine? Where do we have gaps in our coverage rates? Where should we put our best efforts if we're going to contain any possible outbreak or head off an outbreak that might be coming our way? And that's the kind of example where a proper integrated system, a proper vaccine registry, would give us information which we don't currently have and which we really need if we're going to manage population risk effectively.
Thank you. Mr. Farrell?
Thank you, Mr. Chair, and I thank our guests for their comments. I have to say, every time I read a section out of the Auditor General's report, I always get a sense of despair, and it's good to hear that there are many good things happening in the department, and much progress is going on in all these areas. Could you bring us up to date on perhaps what some of the other similar-sized jurisdictions in Canada are doing with respect to moving towards a surveillance solution, whether it's similar to Panorama or whether it's entirely different, and are we coordinating our efforts with what's happening in the other jurisdictions in Canada that haven't opted into Panorama?
Certainly. Well, as part of our strategic intent that we've just been spending the last year looking in detail at our public health information system needs, we did a complete jurisdictional scan to see what other provinces were doing. There's no single solution which all provinces are buying into. A number, 3 or 4, are pursuing Panorama for some elements of their public health information system. No jurisdiction is using one solution to cover everything, to cover all their public health needs. One jurisdiction, Alberta, has, for communicable disease work, opted for a different provider, a system called Atlas. And that's kind of where it is at the moment. And many of the other provinces just are really broadly where we are. So we're not so dissimilar from the majority of provinces. No province has a fully integrated system for public health surveillance as we speak. What has happened in the intermediate years between 2009 and now, of course, is that Panorama has, as one option that we might need to reconsider, has developed, and some jurisdictions are now starting to bring modules of Panorama online so that they are in a better position than we are to have vaccine registry and proper information to manage communicable disease outbreaks. So we're kind of in the middle of the pack, I would say, in terms of where we're up to currently.
Go ahead, Mr. Farrell.
Are we going to end up with some kind of a national patchwork where there is no ability to have a national dialogue between all these different systems, or I guess a network to allow us to share this information across the country?
Chairman, that certainly would be a risk that I think is recognised across Canada. And in an ideal world, obviously, everybody would use one system which can connect up and provide information up at national level as to what's happening in every province. In the absence of that, and given that some jurisdictions will be moving down the route of taking different providers, different vendors, the art will be for the IT specialists to develop ways in which the information can be pooled and centrally coordinated. Yeah.
I guess Microsoft and Apple finally did it, so hopefully they'll get it together as well. Sure.
Thank you. Mr. McGuire.
Thank you once again. Just to have it on the record, I want to apologize to all of you on behalf of this committee. The purpose of this meeting is to fact-find and to get an update, and it's not to misquote columns for political use, so I want to apologize from this side for that. And I just wanted to assure you that your time is not being wasted. So the reporting indicates that all data held by the department should be available to the Population Health Assessment and Surveillance Team. Is this taking place?
Yes, that absolutely is taking place. That is one of the recommendations in the Auditor General report. And just so you know, inside the department we have staff in the public health unit. They have a certain capability in terms of data and information management. And then we also have and they are expert in public health and data information and related data and information management. And then we also have a central group, so we do link with them. And so that is one of the important steps that we have taken, and do appreciate the recommendation from the Auditor General's report to make that correction.
Thank you. Mrs. Ann Lowes-Croft.
Okay. Are there any tools and programs and strategies that other provinces are using that, in regard to surveillance, that you should consider doing in the future, or are you thinking of doing?
Okay. Great. Thank you very much. And I guess just to put that into context before Dr. Atherton provides you the detail, we did indicate here earlier, just so we're clear, is that the estimate for the development of the Panorama system was $10 million, and that was an estimate. And just to be clear, that the actual amount spent was $1.3 million. of which the province spent $400,000. So I just wanted to clarify that detail. The remainder was funding was provided by the federal government. And so, yes, I had mentioned earlier that one of the things we're doing is reviewing the information that was compiled between 2005 and 2009. And we also have taken a number of other steps to ensure that in addition to developing the system, that we are improving our efforts to protect Nova Scotians, and that does include, of course, addressing all of the recommendations from the Auditor General's report. In addition to that, though, Frank can provide some elaboration.
Mr. Atherton.
So the question was to what we can learn from other jurisdictions and other places, and absolutely, we have been looking at that very, very carefully, and as part of our strategic intent work over the last year, to really clearly define our public health information system needs, we indeed did look at every province in depth, and we went beyond that. We looked at international best practice as well, and so we looked at systems that were being developed and being used in the US and in some European
Order.
places.
Thank you very much. Turn it over back to the Conservatives.
Thank you, Mr. Chair. My first question, can you give us an example of a disease that is spread because of limitations of the current public health surveillance system?
Mr. Arrington.
I slightly couldn't quite hear the question. I think you asked, is there a disease which has spread because we don't have a system? Is that your question?
I was asking if you could give an example of a disease which has spread because of the nature of our current surveillance system.
Well, I can't give you a specific disease which has caused us problems. What I can do is to outline where management of diseases, management of outbreaks has perhaps been more difficult than it would otherwise have been. And the example I gave was earlier was around measles outbreaks. You know, if we did have a measles outbreak here in Nova Scotia, it would be extremely difficult for us to know which kids were unvaccinated. We would, in theory, have to go back to a paper-based system and trawl through those, and that would take months and by the time that happened, the outbreak would be over and gone. With an integrated system, we should be able to know exactly where we have pockets of unvaccinated children, get public health nurses to go out, mount clinics, and deliver an effective response. So it's a theoretical example rather than a real one. One more real example is recently in just around Christmas time, we did have an incident in our vaccination program you may well have heard about, where a physician provided immunizations inappropriately to some children, and again we had to undertake quite significant remediation around that, and that involved us really understanding what children had been vaccinated with what vaccine, at what location, on what date, and in what physical location on their body, and that information just wasn't available, and so in the absence of that we had to look to a number of information sources. We had to go and trawl through billing data, we had to trawl through the physician's records and try and compile a picture, whereas if we'd had a vaccine registry, we would have been in a much better position to know exactly who required additional support. So those are perhaps a couple of examples which might help you to understand.
Thank you.
Mr. McMaster.
Thank you. Is it becoming more of a problem again that people aren't vaccinated against things like measles and other diseases that we used to see more often at the turn of the century? Now, I've been reading a book lately, and it's taking place around the time of the First World War, and it's amazing how many diseases the soldiers were encountering and the suffering that they were going through, because I think things have changed a lot from then until now. There's vaccinations for a lot of things. Are we starting to see this as becoming a problem again because maybe people haven't been getting vaccinated in the recent times? And is that potentially a greater risk now than it might have been 10 or 20 years ago, given the fact that our surveillance system isn't what it could be right now?
Mr. Arlington.
So I think we're in a very fortunate position in Nova Scotia. Most parents get their kids vaccinated. We haven't seen the decline in vaccination uptake which some other jurisdictions have seen, and you'll be well aware that there was a particular concern around, in some other places, particularly in the UK, around the MMR vaccine, where parents were misled by false reports of side effects. So we haven't seen that in Nova Scotia. Most parents get their kids vaccinated, and our vaccination rates are pretty good. The problem we have is we don't know exactly what they are because we don't have a vaccine registry. So we do need to build that. But we know they're pretty good because we don't see regular outbreaks of these communicable diseases. I'm old enough to remember working as a family physician and seeing measles on during the winter months on a daily basis, and seeing the misery and the complications that brought. We don't see that these days. We don't see that even in parts of Canada where we are seeing small outbreaks. We're hopeful that we won't have an outbreak of measles in Nova Scotia, but that depends on parents taking those wise choices and having their kids vaccinated. So I'm optimistic about vaccination rates. I think we're in a pretty good position, but we need to have a better understanding of exactly where any gaps in vaccination coverage might be.
And how would you, you had mentioned the example earlier of not knowing who was vaccinated and who was not vaccinated. What would you do right now? Like if there was an issue, would you just approach the public and say, you know, making a public appeal here, anybody who's not been vaccinated, please contact your local physician, your family doctor, or go to your local hospital to get vaccinated if there was an outbreak? Is that what would happen now?
That's pretty much what we do at the moment. Last year we had a couple of cases in the province of a small number of cases of pertussis, and we did use that as an opportunity to remind all parents that pertussis vaccine was available, was safe, and was effective. And we did see people coming in for vaccination and some catch up there. So that's exactly what we need to do. In an ideal world, we would be able to do that, but also to be able to have a more targeted approach, focusing on those children who we would know to be under-vaccinated. But you're absolutely right. Yeah.
Okay. And how would, I know the department has looked at other systems. I know you've been talking about them earlier today. What would the system look like? How would it help? Would it give you, it's going to be taking in information, presumably from various health professionals across the province. What does the output look like? Does it show, can you do like statistics on what's happening and to be able to prioritize where the health system should focus its energy, given a particular outbreak or an instance of a certain degree of illness? Can you give us some example what a system would look like?
So the sort of information that I need as a public health physician managing an incident or an outbreak is, and that we would expect a proper vaccine register to give us, would be not just the population coverage. You know, I need to know whether in Nova Scotia 85% of our kids are vaccinated against measles or 95%. I need to know that. But I need more granular information when I'm managing outbreaks. So I need to know geographically where there are problems, where there are communities which have relative under-vaccination, so I can target resources if needed. I need to know which groups. Do we have lower uptake rates in our First Nations communities? I need to know those kinds of things. I need to know whether some of those socioeconomic conditions which we talked about earlier, whether they're affected. So are people from a lower socioeconomic group particularly seeing under-immunized? Because then I can target messages both for catch-up for campaigns to tackle outbreaks, but also on a routine basis to strengthen the base of the children who are vaccinated, to know where we should put the effort. Where do public health nurses need to make their efforts to contact parents and to educate parents?
Are there massive amounts of money that could be saved with an electronic system, or is it more about better health outcomes that might have a marginal savings for government?
Chair, I think it's both. It's better outcomes, and the sort of outcomes I just talked about are really, really important. But it's also about ironing out inefficiency, and the current system of nurses and doctors filling in paper-based forms, which then go off to somebody else to input into a database, and for somebody else then to do the data checking. There's so much inefficiency in that there will be savings on. Yeah.
Okay.
Mr. McMaster.
Thank you. How important is speed in the response to an outbreak?
Mr. Arlington.
It's vitally important. I mean, the quicker an outbreak is identified and a response is put in place, the more likely it is that an effective response will be put in place. Yeah, it's an important principle of outbreak management that you act promptly and in a timely way.
Ms. Martin.
Thank you. I just wanted to provide further context on some of the questions that we've been asked. We fairly regularly, for a variety of different reasons, have to mobilize pretty quickly and get information out to the public. And so while I know we've talked a lot this morning about the information management system, which rightfully Dr. Atherton has outline the importance of why we need to have a system in place. But when we need to get information out to the public, and so, for example, if we anticipate a heavy flu season, and depending upon the intensity of that, we engage 811, which is a number that many Nova Scotians are familiar with. Registered nurse online who is able to provide information to the public. We provide information out to the district health authorities, and sometimes depending upon if it's a flu outbreak, they can mobilize quite quickly to develop clinics and get information out to their residents. And then not to mention our good partners like Doctors Nova Scotia, and sending information out directly to physicians' offices. So those are all mechanisms that we would continue to use even if we did have a system in place, because it's important to get information out both to the care providers and the public who are relying upon them for services. So that would be a pretty standard way to ensure that we mobilize quickly when we need to.
Thank you. Mr. McMaster.
Thank you. And appreciating that, I mean, there's obviously a system in place now that's has benefit. Can you give us like maybe some indication on a scale of 1 to 10 where you would rate the current system versus, say, more of an IT-based system in the future?
Ms. Martin.
Yeah, so I think that it would be pretty difficult for us right now to put a number on. You know, we have gone through some instances in the past, flu seasons, H1N1, and so on, and we know that the health system can mobilize quickly with its federal partners and district partners and care providers. So certainly it would be assisted with an information management system, but it would be difficult to answer your question.
Mr. McMaster.
Would the current system maybe be, say, a 6 and an IT-based system be an 8 out of 10?
Ms. Martin.
Again, it would be very hard to put a fine point on that, since...
Okay. I can appreciate the response, and I guess the reason I was asking the question was just to get a better idea of, you know, making the investment in a new system, how much better is it going to make things? So that's what I was getting at there. Another question, and Mr. Chair, how much time do I have left? Just 1 minute?
Yep.
One last question. Are there any downfalls to moving to a more of an electronic-based system over a paper-based system? And I think of cases where we might have some kind of a disaster where the power is out. I know there's steps that are taken to protect against that. But can you give? Is there any downside to moving towards an IT-based system with respect to that?
Ms. Martin.
For any system that's developed, especially important health information systems, we would have contingency plans in place to ensure that we have fail-safe in place, recognize that systems are subject to outages from time to time, but we also have a lot of experience because we do manage a number of systems for the province, and we would have contingencies in place, certainly.
Thank you, Mr.
Thank you, Mr. Chair. I'll conclude with that question. Thanks.
Perfect. Thank you. I'll turn it over to Mr. Wilson.
Thank you, Mr. Chair, and I found it quite interesting to hear the member from Halifax Atlantic apologize for political use of this committee. I don't know if he was talking about the fact that each party in this committee brings forward witnesses, potential witnesses, and the fact that the Liberal members on this committee voted every single one of the opposition potential witnesses list down, and we're going to go forward with just the Liberal witnesses as we go forward. So I don't know if that's what he was apologizing for, but I know that it's extremely important for government, for MLAs, when they make comments, when they provide Nova Scotians with information on where the direction government's going to go. It's important for them to defend that, and I'm glad the member from Halifax Atlantic believes he's in a party that allows for free thinking, and that's the concern I have, is that we've seen a comment from the Minister of Health around the column, and I think either the minister doesn't understand the social determinants of health, or he doesn't support them. And I do feel bad that the witnesses are here today having to defend those comments. I know the Chief Medical Officer stated in the email I provided the committee that he can't and won't try to explain the minister's comments. So with that, I'm wondering, Dr. Atherton, if the minister has requested for public health any additional information on the social determinants of health, or has he requested any of the number of studies and reports and papers that have talked about social determinants of health?
Dr. Atherton.
So in terms of the minister having arrived in the Department of Health and getting fully up to date with his brief, there's a whole system of briefings in place, and as part of that, we are talking to him about a number of issues from a public health perspective, including the development of public health renewal, the development of our standards and our protocols. And of course, as the member knows, underpinning all of that is a strong desire and belief in the need to address the social determinants of health. So in terms of briefings being given and received, absolutely, that's in place.
Thank you. Mr. Wilson.
Thank you, and I'm so glad to hear that, and I hope Dr. Strang, yourself, and all your staff continue to make sure the minister understands those determinants. So with that, I will come off that topic and go into another area that is important. I know after the Auditor General's report, I initially stated that I know health and wellness responds quickly and efficiently with the recommendations. The recommendation, the first one, 4.1, has asked the Department of Health and Wellness should expedite the approval process and move forward with the public health protocols in a timely manner. I know you discussed that a little bit in some of the questions. In the government response, Department of Health and Wellness agrees with the recommendation, and the internal Department of Health and Wellness process for approval of the protocols is currently underway. We know that direction for approval of the protocols will be sought from the new government. So I'm wondering, have you been given the direction from the new government on moving on this recommendation?
Ms. Martin.
Yes, as you know, the development of the protocols is an extremely important piece of work with the department. It's led by our public health group, and at the root of it is really re-examining how they can ensure that their efforts benefit more and more Nova Scotians. And so, they will do that by engaging with partners in the District Health Authority, with various organizations that work to improve the health of Nova Scotians, and certainly community health boards and so on. So to answer your question quite directly, it is now policy in the Department of Health that the Minister has endorsed the public health protocols, and they are now officially a part of the Department's policy, which means that they do guide us in the delivery of public health services. And with any new policy, there are certain things that fall into place immediately, and there's work that takes place over time. And this is a policy that falls into that category as well, in terms of it will take us some time to fully engage our partners and ensure that we are improving our service to Nova Scotians.
Thank you. Mr. Wilson.
Thank you with that. And under recommendation 4.2, I know in the response from the department it said that you will be including timelines with that. So if the protocols are approved, is there I know you need to do the engagement, but what is the timeline? There must be okay, let's 6 months, a year. What is that timeline that you anticipate?
Mr. Arlington.
So one of the recommendations was around, do we need an implementation plan? And the protocols are not something which we believe actually needs a plan. What we need is the protocols are approved. They are now official policy. It's a matter of working with partners over time to build those into our system so that our public health system works in a different way. And as part of that, as one example, we currently have, well, we had plans in February to meet with to get a number of people from primary care and public health together to look at roles and responsibilities and how they might shift over time. That meeting was cancelled because of the weather and has been rescheduled and will be held very shortly. So we are now we are in implementation. The district health authorities are currently public health staff and others are looking at the implications for the work, refocusing, moving work upstream, working out those relationship issues between public health and primary care. So it's already ongoing, and as Deputy Minister Martin says, that's something that will happen over the next 2 or 3 years, really.
Thank you. Mr. Wilson.
Okay, thank you for that. We all know, and in the response from the recommendation 4.2, the department did said it will continue to work with district health authorities and community partners to provide guidance and support for the system-wide implementation of the protocols, and that's extremely important. We know that the current government is undertaking a huge transformation with district health authorities, and I'm not here to debate if it's a good change or not. I'll save that for the floor of the legislature. So we are going through a major transformation of district health authorities, and from my understanding from the government that they're looking at everything under the department, the districts, on how they can implement the super board and amalgamation of that. When you do that, people are taken off projects and are taking away from important work, and I've said this before, like the protocols that you just approved. Do you anticipate, and it could be Dr. Atherton or Ms. Martin, do you anticipate that potentially there could be a delay in that because there is this massive amount of work that needs to be done between now and less than 12 months from now? Will it push off that 2 to 3 year because people are going to have to spend some time on the amalgamation of district health authorities?
Ms. Martin.
Thank you very much. So there are certainly employees in the Department of Health and Wellness that will be involved in and dedicated to the work on the restructuring. But the reality is that many of the staff in the department come in every day and focus on their particular subject matter. And in this case, it would be the public health staff. Certainly, they will be consulted and engaged in some of the work related to the transition, but their primary duties won't be impacted. I believe there is a tremendous opportunity, and I do have this conversation with the lead of public health on a fairly regular basis. We really have to look to the opportunity of having a consolidated district health authority at a time when we're coming out with this relatively new protocol. It really is, will create a platform where we have greater opportunity to have consistency in terms of how we roll out this policy or protocol across the province.
Mr. Wilson.
So what I take from that comment is that it would be more beneficial, I think, to potentially hold off on some of the work within the districts, because we really don't know at this time what the structure will be for a number of, it could be primary care, public health, continuing care, all through the districts. And that has been the concern that I've tried to raise over the last little while, around when you take resources away from what they normally do in the districts and in your department. And my concern is, I know that you've answered a few questions in I think it was last week, in public accounts, around soon we'll hear what staff in the Department of Health will be working on the restructuring. But we know that there's staff within the district health authorities that are going to need to work on that also. And that's the concern I have, is that projects like this will be delayed and pushed back. I'm not saying they're not going to be done, but they will be delayed and affected by it. And that's the concern I heard from ministers of health across the country, for example, when jurisdictions undertook a similar exercise, is that what it does is it takes away the resources of people who are working on important projects. I know they're not going to just forget about them, but they do. I mean, people only have so much time in the day. And that's the challenge we have, and that's what I see in front of us over the next year, is a delay in important work like this. So maybe one last question. I know I only have a minute or so. Am I hearing you right that yes, there may be a bit of a delay because really the structure that will have to implement the protocols that the government approved, we really don't know exactly who in the one district and the IWK, who will really actually oversee them. Will there be a delay? A simple question, I think.
Ms. Horn.
Simple question. Answer for that question is I'm very confident that we will move our key priorities. Certainly the Department of Health is a very busy department. We always have a number of large-scale priorities that we move. The work that public health has been undertaking for the past several years is work that will continue. It was in the initial briefings with the minister. The policy's been endorsed by the department, and I don't see the restructuring delaying our efforts to ensure that we're continuing to improve our services to Nova Scotians related to public health.
Thank you. I'll turn it over to Mr. Horn.
A follow-up to a previous question was, in developing your surveillance program, do you feel you have the appropriate full-time staff or adequate staff to look after this and bring it to fruition? And how long will that take you? I think you might be saying 2015. But
Ms. Martin.
So This, just to clarify, is this a question about the information management system specifically?
Not necessarily, but just that you have a complement of experts that can put this program together.
Ms. Martin.
Yes, we do in the Department of Health have a number of information management systems underway at any one given time. I believe last week I talked about our drug information system as one that we were working on the development and the rollout. And there are a number of other systems. So when it comes to the development of the public health system, and we were just in an exchange of questions and answers related to priorities, that the development of that system is a priority. It is in the, and so I'm very confident as the acting deputy for that department that we have the expertise within the department. We also participate in national networks where we are able to benefit from the other jurisdictions who have these systems in place. And we also have tremendous expertise within the department. With any new project or effort, there are times when we go to the marketplace to secure experts from the private sector or the academic community, what have you, whatever sort of expertise we need. And so that is some of what we would do in terms of this undertaking.
Thank you. Mr. Farrell.
Thank you, Mr. Chair. I want to ask briefly about recommendation 4.8 in the Auditor General's report, and it talks about the Public Health Canada's appointment of a field surveillance officer. I realize that that's technically outside the jurisdiction of Department of Health and Wellness, but could you update us on what's going on with respect to the appointment of Health Canada Public Field Surveillance Officer, and if what the involvement of Department of Health and Wellness is in facilitating that getting done or encouraging it being done?
Thank you. Ms. Martin or Dr. Arthur.
Yeah, I'm pleased to tell you that that is moving on very well. We've public health staff have been continuing the dialogue with Public Health Agency of Canada. That's gone very well, and that post is currently in the recruitment pipeline. So we're optimistic that will be in place very soon.
Is there a time target or a time frame set out?
It's really tied into recruitment processes, and they sometimes take longer than we expect. So I can't give an exact date.
Thank you.
Thank you. Mr. McGuire.
So my question is around the field surveillance officer position. We all know this is an important position. What has the province done to encourage the Public Health Agency of Canada to fill this position? Oh, and there goes my mind. Sorry, who stole my question? I'm good.
Okay.
Yeah.
Suzanne Loincroft, do you want?
I had started a question before, and I was cut off because of time. So I was speaking on what we're learning from other jurisdictions on what tools we could be adapting for Nova Scotia. And could you continue on that line?
Yeah, I think where we got to was that we did report that as part of our strategic intent work that we've been doing over the last few months, we did consult with, we did look at all other jurisdictions to see what information systems they were using, what they were planning to use, where they were up to with their particular vendors. But we also did look outside that, beyond the bounds of Canada, and we looked at US systems and some systems in Europe as well. So, so we have a pretty good idea of what is working where. And I think that the comment that was made earlier about there is no single place that we can point to and say there is success still holds true. There are pockets of good practice elsewhere, in different places. So, for example, we know that a couple of jurisdictions, Ontario and Quebec, have used the Panorama program to develop effective case management, and that's already implemented, and they're learning from that, and that's in place. We know that some other jurisdictions, Ontario, for example, has also used Panorama to develop its immunisation registry, and we know that Alberta has some experience with a different vendor, a different system in those two areas as well. So we do continue to look at those other jurisdictions. We have a public health network and an public health information steering committee as part of that public health network, which helps us to bring that kind of information on a regular basis back into Nova Scotia. So yes, we do look at successes and failures elsewhere.
Thank you. Mr. Farrell?
We don't have any other further questions from here, Mr. Chair. Thank you.
Excellent, thank you. Ms. Martin, did you want to have some closing remarks?
Great, thank you very much. Thank you very much for all of the questions today. It has been a privilege to appear here today to further elaborate on the good work that our public health group is undertaking. It's an opportunity, of course, to explain that, like any other area, there are challenges with updating our public health system. But what is important is the progress that we have made and do plan to make in the coming year. As I said earlier, the Auditor General made note of numerous improvements that were needed in our surveillance work. We have agreed with all of the recommendations of the Auditor General, and we've taken action on all of them as well. While it will take some time to finish our work to secure the best option for an immunization registry and the other components of an integrated electronic public health surveillance system, we are moving in the right direction. Thank you.
Thank you. I think we're finished with you guys. And I guess we're on to other committee business. Hang on. Is there any other committee business? No, hold on. Hang on. What do you want? Committee business. Suzanne Croft.
Thank you, Mr. Chair. Our colleagues in the Progressive Conservative Caucus have proposed that next week that the Department of Labour speak at the Committee on Workplace Safety, and they have proposed 3 topics. And I would like to introduce a motion to merge these 3 topics into one, similar to what we've done on our pension topics.
Are there any comments on this? Mr. McMaster? Mr. McMaster?
Thank you, Mr. Chair, and I certainly would have no problem with that.
Okay, great. Thank you. So, do we move a motion to vote on this, or is it passed? Farrell?
Would call for the question on the motion.
All in agreement, say aye. Aye. Any opposed? This motion is carried forward. We'll take I guess the next meeting of the committee will be on Wednesday, April the 23rd with the Department of Labor and Advanced Education regarding occupational health and safety. We now stand adjourned.